one hood. Now it is working at the edge of the nucleus edge, and it is gradually it will come to the anterior chamber.
Excellent.
Very nice. Very nice, I think. Very difficult and very
Yeah.
nice, very elegantly done.
So I am making sure that it is in the anterior chamber. Good viscoelastic. Okay.
Anil,
Reduce the magnification, and you can see this. Yeah, I go one side and
what's the equator?
rotate this,
Sure.
and now I cut the nucleus.
Endothelium is not touched in any.
No, no touch, not touch. You can see the cut. It cuts the nucleus into two half.
Yes. Very nice.
Making sure that the nucleus are separated. It's a very hard
You can
nucleus.
see this. It is not separated yet. Yeah, now it is separated.
So hard. The steel wire has not cut through.
First, I remove this. This is the crocodile forceps. You can see this hardness.
With the crocodile forceps,
This is the posterior curvature. This is the anterior curvature. This is the real heart one. And now give a little bit of viscoelastic again.
This patient we had to bring from one of our peripheral branches today just to demonstrate because Professor Namrata Sharma wanted us to show this case. Essentially, we didn't have it in Barrackpur.
I'm sorry, I
It's
must
very
be on the
fortunate that this gentleman will be getting a J&J sensor platform lens. We really prefer that platform of lens because the PCO, this patient is going to have PCO. We're going to correct his astigmatism by this instrument. And we have respected the endothelium as much as possible. Tomorrow is going to have a clear eye. And on the longevity part, because in SICS you have to do a big Lexis, and especially with such a hard cataract. So there, I would also want Professor Namrata Sharma's experience. We see that this Technis platform lenses, they are back fit lenses, and they fit very well in the capsular bag and does not rely on the capsular margin overlap, the shrink wrap effect for that PCO prevention. What is your opinion, Professor Sharma?
No, I completely agree, sir. I think the PCO is because of the fact that it sits so snugly and so tightly clinging to the back that chances of PCO, I think, are much less. And like you said, the
See,
overlap.
I have started with the Cinco, but I thought I am not confident enough after so many days, so I switched to bimanual technique to aspiration.
Very nice, I think. And I just want to highlight the fact that we have on YouTube the highest number of.
The stability of the everything is absolutely okay. And we load our lenses with Elon.
Now it is a glow is very obvious.
Yes, very nice.
And so, Arup, can we implant the lens?
Okay.
That was actually very quick. The whole surgery was actually very quick. And sometimes you think it is better to do SICS in such cases than to, try to phaco them.
No, I mean, this was more to respect the endothelium. And
Yeah.
yes, I mean, there are two kinds of trauma. There's an incisional trauma, which is more in SICS, but and less in phacoemulsification. But there is a corneal and a intracameral trauma, which in this case would have been quite high. So essentially, we opted to do an SICS, and we do practice this. So this is we have implanted a star-synthesis lens, and thanks to J&J that this patient gets this lens. But we are very fond of these lenses. I mean, we 55% of our
So you can see this. My axis is almost 7 millimeter. Almost 7 millimeter. It's 1 millimeter behind the lens. This is the. I think this particular case, this is probably the only disadvantage. I think the axis is overshoot by 1 millimeter beyond the FT. But if you consider it is this surgery in this particular more cornea friendly and yeah. Patient is excellent, well, cooperating so much.
You can see that
he is under topical anesthesia. I always prefer to. Do you have a Pilocard, Taro? I prefer to put this Pilocard basically in all cases, my cases, because and this particular case there I have used a lot of viscoelastic, and as you know the pilocarpine increases the UV scleral outflow. So post-operative IP spike is much less in cases of if I use a Pilocard. And at the end, I just try to wash my tunnel because there is maybe some kind of cortex will be in the tunnel. Can I have more water? DSS. Mr. Shahid, চোখটা ডান দিকে নাড়ুন তো বাদিকে ওকে
So the patient we asked the patient to move the eye just to demo to the audience that
I am completing my case. Thank you so much AIS for giving me the opportunity
and anesthesia for SICS. I mean it's just a mind block. And even if the patient is not as cooperative as this patient, there is a subtenon anesthesia. So in between also we can give a subtenon anesthesia. Thank you, Arup.
Thank you so much AIS for giving, and thank you Johnson and Johnson for organizing this Surginar.
Dr. Arup, I think that was a very quick surgery. I never expected it to finish so fast. Especially in such a hard cataract, but I think that is the magic of SICS and the magic of your hands. That was done so fast. Excellent demonstration of your snare for the hard cataract, and very nicely done. Can we have the details of the next case? I think they are.
So yes, Namrata, the next case is a staff of ours. So we again thank J&J because she'll be undergoing a synergy. J&J. She had undergone a synergy in last life surgery, which we did in Professor Jeevan Titial, head of AIMS, had come. So probably he did, I don't know, in the other eye. And now we're doing the second eye for her. So she'll undergo a synergy. So I'll just run you through her case. In one eye, right eye, actually this was the case history is before she underwent the surgery. We'll show you the patient. So this is today we will be operating the left eye. And so this is the optos picture. This is the pentacam. She doesn't have much astigmatism. And so this is what she has, 0.73 at 77, which at her age is perfectly all right. So we won't address this. And so we go to the catalyst section where Dr. Sanjeev Banerjee will be performing the femto procedure. Over to you, Sanjeev.
Thank you, sir. Thank you, AIOS, for giving me this opportunity. And this is our treatment plan. So capsular rexis size is 4.8 millimeter. We are keeping scan capsule center method choice because it will detect the anatomical center, and which is very much essential for the any premium lenses. And that's why we counsel all our premium lenses presented to go for the femtosecond cataract surgery. So now coming to the main docking part.
Can we have the external camera properly on the docking procedure?
Camera, please. Yeah.
File তোমার তো একবার হয়েছে, so
File দেখো
তুমি সব জানো।
ফাইল চোখটা খোলো। আচ্ছা, no, okay. Ready?
If you can show from the other side, the camera can be taken from the other side.
Yeah, sorry.
The external camera can show. Okay, now we can see. We can see now. Yes.
Yeah, I mean, yeah, this is these PIs, they fit very well, and
Okay.
and because of the liquid interface and all the days of, I mean, this catalyst machine, they give wonderful rexes, free floating rexes in almost every case. And what it does is actually, as Sanjeev said, that it centers the rexes on the capsular bag, which is perhaps more important. And so
Okay, so Sanjeev, are you going to make the incisions also only, or the rexes and the nuclear emulsification part?
Sanjeev,
I think.
can you?
Are you going to do the incisions also, bone construction, or only the rexes?
No, ma'am. I'm not doing the corneal incision because I do not like this clear corneal incision because it is very anterior, quite anterior to the limbus. I prefer the incision over limbus, and which is limitations of these femto machines, because sometimes it do not open.
Yes.
The scanning is being done, and this anterior corneal surface, posterior corneal
What is
surface.
Namrata, we focus on this is that 4.8 millimeter rexis.
Yes, sir.
At the that's the 4.8, which is centered in the capsular bag. So this is why we ask the patient to spend 20,000 rupees, because he's spending so much for a lens, and we want a plano. We want to be bang on, and so, you know, that's the whole idea.
0.8, fine, perfect, approved. Let's.
Okay, so I think the rexes and the
And this patient is very young, as I told you, she's asked now. And the cataract's very soft. And I don't know.
So we are doing a 4-quadrant division and no need of nuclear softening because already it is a very soft cataract. It's done. It's very fast.
Yeah, I think it is.
Right. Thank you, Sanjeev, for an excellent demonstration. So this is mostly this is what we use, and we use the astigmatism corrections wherever required. In this patient, it wasn't because a 0.73 astigmatism will be taken care of, and we are now going on to the next theater. But before that, I have to give you the case details. Where Dr. Mrinmoy Das will be operating chlorotic patient. After that, Dr. Sanjeev Banerjee, who's a very brilliant surgeon, will take up our pile staff for the synergy implantation. So this is the patient Ashok Rai. So he has a cataract in the left eye. His other eye has been a pseudophakia elsewhere, which he has a cylinder of 2. So now that we can correct his cylinder, this is his OCT, this is the cataract, which is grade 3 nucleus sclerosis. This is his optos, and he has a good specular. And we have done a toric which reconfirms the cylindrical values that we get in the biometry, which is he has 2 diopters of cylinder at 30 degrees, right? Yeah, and we go over to Dr. Mrinmoy Das. Mrinmoy is also being a surgical surgeon with Chitrakoot, an institute which does 1 lakh cataract surgeries every year. And for the last 10 years, we are very fortunate to have Mrinmoy with us. So over to Dr. Mrinmoy Das. Yeah, Mrinmoy.
Thank you, AIOS, for giving me the opportunity. And this is a case of NS grade 3 to grade 4. And I am using the Signature Pro machine along with Varian. So first I am putting the incisions. I am trying to follow the image which is showing the machine. I am putting a xylo card, putting viscoelastics.
Getting our signals properly?
Yes, sir, very nicely. We can see everything very well.
Now I'm going to make the incision. So I'm trying to make a 5 to 5.5 millimeter axis.
So I think the Rex's mark can also be seen when you are doing the Varian.
Yes. So I'm trying to make a 5 to 5.5 millimeter axis.
Yes.
I'm trying to make it a rounder one. So my axis is complete.
Yeah, perfect. That's a perfect round Rex's.
Now I'm trying to make the hyperdissection. Once the fluid passes the center, I will try to just tap to take out the remaining part of the fluid behind the nucleus. And I am trying to rotate the nucleus, and yes, of course, it's fully rotated. Now I am putting viscoelastics again. Now I am going to starting the phaco. Phaco 1. So first, I am first trying to make the center range, and now just change chop.
Yes. I think the parameters are very nicely seen on the screen. The screen signature has been shown here and very well it is
So
establishing.
the nucleus divided partially. I am trying to first divide the nucleus in total
Yes.
along with the posterior plate. I think it is done. But again, I will check first. As the posterior plate, yes, it's almost done. Now I am going to chop the nucleus into 2 to 3 more parts.
Appears to be a hard cataract. It's not that
Yes,
soft.
yes, it's a hard cataract, not that much soft. But okay, let's see.
Very nice drops. Perfect drop.
It's divided almost into 3 parts. And now the other part. Yes, this is another. And this is a hard cataract, so I am trying to make it in a multiple piece. And now now the quadrant one. So this machine is the in this machine it is the blending of that horizontal and the longitudinal longitudinal power is used, so it is not that much difficult. And I am trying to put my phaco probe in the center.
Very nicely done. Very nicely done, Dr. Bimanual.
Now during the last part, I am trying to take my chopper at the side port, so that there should not be any surge. And I have
Very nicely done.
now my
That was beautiful.
stop. So some part of nuclear material is there. I usually use viscoelastic to take this out. Otherwise, sometimes it can be missed out and it can go between the eyelash and enter capsule, and sometimes it is very difficult to take the smaller parts. And later it will come to the anterior chamber and there will be corneal decomposition starting. So the smaller part should be taken out with viscoelastics. And now I am going to do the IA part. Treats as usual. First I am holding the cortical matter, taking out the second in the center, and then with the help of the other instrument I can take out the cortical matter.
Very nice. I think excellent demonstration in the bimanual irrigation aspiration also.
So now there is some part of cortical matter in the posterior capsule. I always try to do it with the hydro. I'm trying to clear the posterior capsule as much as possible.
Kind
And now I'm
of flush the posterior capsule with a water jet. That's what the Nirmal's point of view.
so So we'll put the nucleus in hydro mode. So first I have to wait to unfold the lens properly, then I will align it.
I think you can see it is just 2 degrees off the axis where it's reading.
I think that it's almost in the
Yeah,
axis.
almost on the axis now.
Namrata, I mean, this patient didn't have a toric in the other eye, and
Okay.
he has a 2-cylinder. Now, I mean, with this probably he's going to hit yellow. And
Yes.
this T2 models of techniques, we think that the, what you want to know your experience and the age experience, where rotational stability is very good because, this frosted haptics and all, it doesn't rotate, which was a blemish previously with technique toric platform.
I think alignment is proper.
I completely agree, sir. The more recent platform is better rotational stability, and I think that is basically because of the material that they have changed.
The other thing, as we were saying, you can appreciate the backfit thing of the lens, and it's usually posteriorly fixed, and obviously the AB numbers are great.
So,
And,
so my surgery is over.
Thank you.
Thank you.
Thank you so much. Thank you so much. It was a wonderful surgery, Dr.
And now we go to the Femto, our client, our staff is receiving the signature in the other.
Yes.
So he is good to go. I mean, can we go to the next paper, please?
I think everything is moving so smoothly. All your teams are geared up, and one thing gets over, and the other team is ready, and then a third team again ready in the flags. So we are now going to watch the flags case, which was done by Dr. Sanjeev.
Yeah, the flax patient. So now we're going to implant the synergy. Sanjeev, can you show the other eye of file which has been operated on? Can we have the microscope camera? The microscope camera.
Microscope view, please. Operating microscope view, Gaurav.
Ajit, can you show me the microscope view of the patient, please? Yes. And if you allow me to talk out.
actually great way. Next time, end of the study.
We'll see it later. We'll see this side.
চোখ খোলা রাখিস কোনো অসুবিধা হলে বলবি না
হ্যাঁ ঠিক আছে পায়েল, কোনো চিন্তা নেই, তুমি আলোর দিকে তাকাও। হ্যাঁ, দুটো চোখ খুলে রাখো, একটু নিচের দিকে তাকাও, আর একটু হ্যাঁ এইরকম থাকো। হ্যাঁ
সুন্দর করে এটা দেখে দেখাবো, শুধু হাইপার আমাকে হাইপার দেরি করে।
ঠিক আছে পায়েল, একটু নিচের দিকে, হ্যাঁ এইরকম থাকো। হ্যাঁ
বলে দিছে যে মেশিনে গন্ডগোল আছে, মেনশন করে।
হ্যাঁ হ্যাঁ
আর রিপিটেড ইন্টিগ্রেশনের উপর ঠিক হচ্ছে।
হ্যাঁ না ইট ইজ
আর ইজ ফ্রি ফ্লো। তুমি বলো। Both the machine has some problem in the anatomy.
স্টার্ট।
Yeah. Sanjeev, you can start.
Yes.
Yeah. You can see, demonstrate for.
So- So this is not a free flow cut. So this part that is clearly cut, but this is still attached.
Yeah.
So maybe we need to do it manually with the help of a Equator faucet. .4.
Careful. No, there. So this particular case, generally in catalyst you saw these are free floating capsule, but this particular case there is a no free floating capsule. So surgeon have to be very careful during removing the anti-capsule, because any untoward movement can end up to run away of rexis. So you have to leave the rexis once where there is a full thickness, and gradually you have to peel like your rexis very carefully, so that you will not make any tag in the end, because if you get some kind of tag, it can give way during the surgery, any kind of pressure fluctuation during operation. So wonderful, Sanjeev. Wonderful. You have to be very careful when there is a no free floating of capsule.
Spatula. So now what I do, I manually separate anterior capsule from the cortex, because it will help in fluid to pass, and there will be no chance of fluid entrapment, just like what we do in posterior polar cataract. Sometimes we separate the anterior capsule from.
Young patient like we use in you. So
Yes.
I think and it's absolutely particular cataract.
I think here you cannot be that vigorous with your hydro procedures as you would.
Yes, this is very soft.
Yeah.
Gentle hydro will do.
When you're doing flax, there's some air which is trapped behind. So one has
Yes.
to be careful about that. It will just come out,
No.
drop out.
Sure.
The hydro maneuvers.
Animated. Go ahead. মাথা নাড়িও না, ঠিক থাকো। This is very soft cataract.
Always used to do it separate. I think the chops are already made.
It is already made and very soft cataract, like only cortex. Maybe we can aspirate. No need to go for.
It's a pleasure to watch. We saw very hard cataract and now very soft cataract. Other end of the spectrum. Yeah.
Yeah, I mean, yes, soft ones are actually very challenging. Totally a 2.8 axis because you want a good lens overlap and excellent ELP, predictable ELP for these patients.
No. आइए.
Because of the application, the iris lens with diaphragm is also very labile. So as soon as it came out, the pupil became actually dilated.
Yeah,
And
the
the iris
patient is myopic.
People when put the fluid inside, it just dilates. And when you take out the fluid or take out the instrument, it dilates.
Yeah.
Breathing pupil of a high myope. I think this step becomes a little difficult with the flat procedure. Not difficult, but little different.
Yeah.
The fibers are already cut, so you have to go and seek the fibers with the bimanual rather than coming out with it. For us here, it is very nicely focused and everything can be seen very clearly. Every single fiber, every single vessel is very nicely visible. I think this is because of very good operating microscopes that are present there, sir, in Disha.
No, these are, are the standard Lumira eyes.
Yes.
And we have, the cameras are very simple. Actually, we have security HD cameras. This cost about 20,000-30,000 rupees. We buy in bulk. And so these are the cameras which are attached to every microscope. So the assistant also gets and any fellow watching and we can guide fellows during this.
Yes.
I mean, with a young patient, can be really sticky. Type of preparation.
Can have a nuclear, not this actually is a little different because this is too thin for a phaco and a little thicker for the irrigation aspiration.
Yeah, absolutely.
And like I said, you have to go and seek it from within the furnaces because the fibers are cut.
Sanjeev is a very good corneal surgeon also, and so he has patience. So, he's not that quick and will take his own time to clean and do everything. You need to break that. Very trap.
No, no. No, too funny part is little bit of, I need some visco elastics. Some visco. Arekto diyor. Lens diyor.
Did you do hydro implantation of the IOL?
Yes, ma'am.
Okay, so no viscoelastic is being used, the lens is being implanted using only irrigation from one side. Beautifully done. Excellent. I think that
Yeah, and we also, Namrata, load the lenses with Hilon.
okay.
So essentially, what happens is, by the time you don't have to clean much of viscoelastic. So, one, it saves time, and second, viscoelastics left.
The synergy lens, I think you can see the rays. Again, beautifully focused here. And much compliment on the microscopes and your recording systems, sir. They are
and Lumira Eye and Lumira Eye. Cameras are those, I told you the HD cameras, Korean security HD. Giving a little pilocarpine, giving a little lens is very well sent. The lens is very well sent.
आलो लेके आता हूँ आलो since the jol down. I'm putting little bit of pilocarpine.
very nice done, Dr. Sanjeev. Very nice done, Dr. Sanjeev. We realized the lens was also implanted. I thought that, we are going to do it, but very nicely done. Hydro implantation of the
Thank you, madam. Thank you.
So after that, we will do enhanced case and we can talk about the lens also a bit, and I'll introduce the case study.
Thank you very much.
And all kinds of
Thank you so very much, sir.
we go to the next case, the eye hand and the pilot also. So I think, yes, sir. The next case, yes, sir.
So now we will be operating this patient, Mr. Manush Kanti doctor, and The slide's not moving here.
No slides are there, sir?
Can you see our
I can
slides?
see. Yes, sir, I can see. You've shared
Yeah,
this.
okay. So this is the OCT of the patient. This is the cataract. It's a grade 2, 3 cataract. The specular is fine. The optos is also fine. Actually, we do a lot of optos. We have 7 of them,
My God.
which covers the bigger hospitals that we have. So we use them to the fullest, and everybody undergoing surgery also goes through an optos if the media is clear enough.
Okay, okay.
So these are the pentacam, and the patient has a low cylinder. So the pentacams also agree. And so we will be implanting, and the patient is a little myopic. So a little enhanced depth of focus lens will help in this case, which I enhances. So over to Arup, and Arup can take over from here.
Thank you once again, AIOS and Johnson & Johnson for this wonderful Surginar. Hello.
Yes.
Can I have my screen?
Yes. Can we have Dr. Yeah.
Yeah. Yes. This is a grade 3 cataract, and this is the beauty of surgeons are in basically told is a lies between your incision and rhexis. So after 1 month, all surgery looks same except incision and rhexis. So I try to do a 5 millimeter or 4.8 to 5 millimeter rhexis. This viscode I use often in many of my cases because it protects endothelium, and this is a hyaluron, which a IOCare product, but excellent. This is a, if you consider with the vis-a-vis other product, sodium hyaluronate, definitely Vilonjavi is best, but if you want to use the low cost sodium hyaluronate, then definitely you can consider IOCare hyaluron product. So before I start, I just make a mental impression how much I'll do my rhexis, and I start my one side, and I'll do rhexis of 5 millimeter. So that it will give a good capture overlap. Here I will be more cautious during end of these rhexis and make a try to absolutely round rhexis. So I have a reasonably good rhexis, round
Very
rhexis.
good rhexis.
Yeah. So before I do hydrodissection, I express some amount of viscoelastic from the anterior chamber, and then I rotate this. And I'm using Signature Pro. This is a wonderful machine, though I very few time I'm using this machine. In my OT, we are using another machine. Can I have a Phaco 1? This is a long pulse. Make a central catheter, and now I chop.
This has both the venturi and the peristaltic pump.
Yeah.
Unique combination of
Yeah.
pumps. That is the advantage of this machine, and it has a LF Apex technology. So it cuts very smoothly. Very nice demonstration of chops.
Yeah, I just. See, the difference between this system and other machine I use, where there's a very difficult to do a complete occlusion in if you use more than 20 gauge tip. If you use a 20 gauge tip, it is very easy to occlude. But even consider the Centurion machine, most of the surgery is done in a partial occlusion mode.
Yes.
So this is a chopping. I think I can now emulsify.
Yes.
Yes, this is a very fast and stable anterior chamber. I am using quadrant removal mode. They have a unique combination of ellipse and longitudinal say phaco energy.
I think perfect chamber stability
Yeah.
because of this automatic occlusion sensing which it senses. The chopper, what is the chopper that you're using, Dr. Arup?
I'm using Apashami combo chopper because I going for the last feed phacoemulsification. I always try to put some amount of viscoelastic here because unknowingly you are doing more anterior plane near antechamber because it is. So I always put some amount of viscoelastic. Even I remove my chopper from the left hand so that it is relatively less leaky. So, I always keep my viscoelastic in left hand in end of the surgery.
Very nice.
Emulsification.
Very nicely said.
So
I think two things which
I
were
do
very nice.
bimanual irrigation. This is my little innovation, improvisation rather. You can see I have a frosted irrigation,
Yeah.
and you can see there is a one notch in the irrigation
Yes.
so that it can scratch the equator so that there is a remove as much as any cell during aspiration. I am showing how to use this.
Okay.
Removing.
So this is available with somebody's marketing it or
Yeah, this is Epsilon
okay.
product. Is say they make it a aluminum. It is a very light one. Alloy, sorry, aluminum alloy, not aluminum. Can I have a polish? Yeah. You can remove the all the during polish. You can search for any kind of fiber in the equator. You can.
You're polishing the anterior capsule also.
Yeah. I always because unless you polish the capsule pearl, you cannot see how much fiber is written in the equator. So sometimes it's very difficult to see. So it is better to remove. See. So now I can see this. There is some fiber here. Yes. Now I am sketching the equator. With irrigation on, can I have a bottle height, more bottle height with the irrigation one up to the equator.
Okay, I think that is a very good technique of
You can see the notch.
yeah,
You can see the notch, so that I can remove little bit early cell from the equator. So and now it is a time for oil implantation. So this is
Again, you are
a
doing
actually nice, nice.
hydroimplantation.
Yeah, you can see the Hilan.
Yeah.
This is a nice lens.
And we can load 10 to 15 lenses with Hilon. Actually, we prepare aliquots of Hilon, Hyaluron or Viscoat,
Yeah.
Xylopart, and we keep it in a separate box. And these are made, say, suppose the one table is doing 20 cases. So the surgical assistant will make these boxes and keep it in the drum. So one after the other, and he uses a double glove technique, and the surgeon is also double glove. So he just takes off his outer gloves. He will change the tip and sleeve, and also a sleeve on the on the phaco handpiece. And this is how we change in between cases. So this is how we, these two cases were simultaneously done in the same operation theater.
Okay.
I mean, one after the other, because Basak is getting ready with the DMEK in the other, which we will soon follow.
Okay.
So my Rexis is good enough. It is almost some size. It is 5.2 and some area it's a 5. It is completely overlap the optic margin. And this is my one of the my most preferred lens, Eyehance. And this is a present days monofocal lens. And it's a you can see the focus graph. It is able to it is give a +1 advantage for the near vision. So this is today's this is a in today's scenario, this is the today's monofocal. Probably all monofocal lens will be replaced by this type of lenses.
I think,
Thank you so much.
Thank
Thank
you.
you, ma'am.
Thank you, Arun. Thank you.
Thank you.
Thank you for a wonderful demonstration. And now we will go to Dr. Basak's surgery.
So excellent demonstration, Dr. Bhaumik. I loved your SICS, your snare, your discase, and so many tips and tricks like putting viscoelastic, putting viscoelastic just before you take the last piece, and then so many tips and tricks that you taught us while doing your surgery. And of course, it was a pleasure to watch your irrigation aspiration. I think I'm going to very soon shift to that half capsule on. It seems absolutely right to use this irrigation aspiration.
So actually, Professor Namrata, we are sharing the, and we have the previous slide, we're sharing the year-wise, total, I mean, we have a huge preference for the hydrophobic lenses. All lenses that we implant, the entire 83,000 are hydrophobic lenses over a year. So this was 2021 figure, and out of which a good 70,000 are lenses from Alcon and J&J, because they are so predictable and value for money. But also the remaining 10,000-12,000 lenses are the Indian hydrophobics, and we are slowly also using the Indian hydrophobics because the prices are good, and now the standards are really improved. And to show you another macro statistics is the amount of toric lenses which have come up. In 2015, we were just doing 158 torics of maybe 50,000 IOL scenario. Now we are doing almost, of 80,000, we are doing 4,000 lenses, which are pretty high. But ideally, we should be doing almost 8,000 lenses, because we choose to toric in the region of 1.25, 1.5. So if you see the total cylindrical population, it will be around that maybe around 10%. So we aim to use around 10,000, 10% toric lens. So we are now going over to Dr. Basak's theater, where he will be taking us and explaining us his procedure. He runs more than 1,200 to 1,500 every year. So,
Yes, Namrata, can you hear me?
Yes, sir, very well. We can see your
So,
and
patient, you can see the patient, this is 60 plus male. This cataract operation was done 3 months back elsewhere. And you can see this is a SICS. This is the previous incision. So this was SICS, but unfortunately the other eye is pseudophakic, very good pseudophakia. And this eye, I have proposed my incision here. You know that I am from the head end of the patient. So I am just first removing the epithelium because these are, I mean, moderate to severe kind of corneal edema. The corneal CCT is around 800, so 820. So I am removing the epithelium. Now I will mark it that proposed like 8.5 millimeter mark. Center acheta.
we'll have to center it a little bit towards you.
This is 8.5 millimeter mark.
Yes, sir.
Ah.
Slightly towards you. Yeah. Now it is okay. Well, perfect, sir. Perfect.
So I am reducing this thing. So I do side port first. This is side port, not fully because this is only DMEK, not a triple procedure. So we don't need a bigger side port, like half of the normal 15-degree blade. And I always mark the side port because at the end you may lose the side port when you are in a hurry. So I give first pilocarpine so that pupil should be down, and you see that pupil is beautifully constricted. The anterior chamber depth is perfect in this case, not so shallow, not so deep. So pupil is, iris color is also little lighter side, that is also good. And this time I give trypan blue injection, and then I do, because it takes little time, so I give a little post-limbal incision. It is 3 millimeter post-limbal, and it must be within that mark. Fill out.
So, Dr. Basak, I think we do DMEK as only there for endovascular almost.
Now this wound is here, so I have given a separate wound. Otherwise, most of the people used to do temporal, but in this case, because my limitation, I always do superior incision. And this is Hilan, and I will do the Desmet scoring now against the trypan blue stent. So I have mark of 6.5 millimeter. My probable diagnosis in this case is probability of TAS cannot be ruled out because I could see the pigments on the back of the endothelium. After removing the epithelium, the clarity is little better.
So what percentage of your endothelial keratoplasty is DSEK and DMEK?
Pardon, I have. What is the?
Endothelial keratoplasty, what percentage would be your DSEK and what percentage would be?
No, still DSEK I am doing since 2000, I think 5 end, and DMEK I have restarted from 2016. So right now DSEK I have done almost 1500 plus, and DMEK it is just crossed 1100. December I have because I have given a post, you have seen that 1000 DMEK I completed in December, I think 24th December. So after that, within this 6 months, I have done 100 plus cases. Every month I used to do 18 to 20.
I saw the forceps was a little different. The forceps with which you were taking out the desmets in brain, it has claws.
So here I will do now the inferior PI. Usually I do with vitrector, but sometimes where there is thick arcus or you have dark color iris or you may not, then you can do external side port. ঠিক আছে? So you see that beautiful PI has been, can you see it, the PI?
Yes,
Yes,
sir.
yes, we can.
So you see the retro illumination, you can see the glow also from PI. So PI the air the. So at this point I give air for two reasons. One is to give this একটু জল দেওয়া হবে আই ওটা তখন আইটা করা হয়নি little bit visco is still there, so I mean Hilon is still there, so I have to আরে bimanual হঠাৎ কি হলো তোমার
Elon is something viscoelastic should not be.
Hilon is there because that air bubble will tell you that Hilon is there or not. So I need to clean all the aluta ekটু বড়. So basically from all around, especially from the angle, you have to remove Hilon. Hilon is that way is very easy to remove, unlike other cohesive viscoelastic the air the. So at this point I give air and air so that oozing can be stopped from the PI side. Also it helps in reducing some amount of edema. You will see after 3-4 minutes when I prepare the donut tissue. This time I prepare the donut tissue. So I have always a special table designed for cornea surgery so that I don't waste time on shifting my microscope. You see, it is just beside patient other eye. It is just in front, and it is a flat wooden the central mark. Centration dekho. This is 9 millimeter mark externally I do, so that internally when I mark I can mark it 9.5. So this is 9.5. Just light touch. Always there are fine which are like 150 or 200 micron, but those are so expensive. And this Modhu instrument is very good. It is so, for Indian perspective, it is so good.
What is the age of the donor?
The donor age is 70 and count is 2863. So otherwise very good morphology. So you know that I prefer to do this 9.5 millimeter. Then from the Solvis line I remove the, and this sign I always tell that this sign is very important. Well, it comes very easily like this one. That means this endothelium will behave very quickly. Can you see it?
Yes, sir. Yes.
So this is a very good sign. Sometimes it cannot come so easily. So you see that it comes almost 360 degree. That means this endothelium will not give me a problem of the Jalda. So again little bit of trypan blue so that I could see the edges very nicely. So is it centered now?
Yes, yes, sir. Yes.
So I go to find out the cleavage between. This is despite endothelium. That is a new technique I devised during COVID time because of to use the same donor for two split cornea technique.
So what
So
is this
if you-
instrument? What is this instrument?
It is Boschak splitter. I have not named yet. It is just like you can use even the sharp chopper also.
Okay.
But the tip is not that sharp. So you could get this cleavage very nicely. Previously I used to do with MacPherson, one end. But nowadays I could, and if I were beautiful that you see that I am going so one-handed technique.
Yes.
I am not using any forceps, no, I mean vacuum kind of trephine. People are a lot of obsessed about the vacuum trephine for this dissection, but it is not required. And you know the cost of those vacuum trephine, and you see that I am going for 360 degree. So when I am sure that I have covered 360 degree, I choose an area where it is closer to periphery. That means this area I will choose. Again recheck the thing that my area is clear or not. Yes, it is clear. So I will start from that point. So I always try to do little peripheral. Sometimes the tissue may be fragile. You see that it here little bit torn. So I will choose another area.
And what is this? You are using MacPherson to lift this?
MacPherson, yes. MacPherson, simple MacPherson. But this must be very, very good MacPherson. We use the Epsilon one for a long time for other purposes also. You see that it is come so easily. So easily. So little bit side to side movement sometimes you have to give, otherwise radial tear may happen. You go up to like 80%, 85% of the total thing. Then you just do a little peripheral 3 millimeter punch. This is through and through. Stromal punch. So now you float the DM to your original position. Soak it little so that it should stick with the posterior surface of the stroma. You flip the cornea and give me a little, so we know that it is not completely separated. Sometimes it looks elegant that you are doing like this, but it is not intentional. Sometimes it happens and you feel good
Yeah.
that it is just like a lead, you are doing it. It is not purposeful, it has happened. And when it is happened, but if it is thicker, then you have to cut it. Then again it will cause problem. So when it happens, it is good. I just soaked it. I always use two sponge, different kind. One is cellulose sponge, one is PVA. Both are important because cellulose have small bits. Sometimes it sticks to the DM side. Now I will put an A stamp. I make it little vertical so that your A stamp will be, your hand will not obstruct your view. So this A stamp is lighter in things, so that lot of ink, alcohol is there, so you should avoid lot of ink because it kills the endothelium. So you just flip it back, 1 drop of BSS. Just to prevent drying, you just put 1 drop. Previously I measured it, it is 8.5, so 8 millimeter is the perfect in this particular case. So I will go little peripheral. So this is my size of the graft.
What is the size of your graft?
This is 8 millimeter.
How do you
The
decide?
define is 8 millimeter. The previous mark told me that 8.5 millimeter, then peripheral clear zone is also there. So 8.8 millimeter is standard most of the cases. So just soak it to see the area of dissection and you remove the peripheral. This is the area you must be very careful. This is sometimes you have to tear it. This is a ring like thing, but you have to tear it, otherwise sometimes they can the sponge there. Sometimes it causes radial tear at this stage also. So in every stage you have to be very careful. So you remove it as a whole. So central part is there.
Very nicely
So,
done, sir. Very beautifully
so
said.
now you just do it like this. And here also you have to be very careful and little bit like Rexis kind of movement, otherwise again there will be tear of that part. So you see that this is I used to call this DMEK PD. So I take from one side of the peripheral and it is always gives you. So I put little trypan blue and I will come back to the patient. So I think around 3 or to 4 minutes are required to prepare the tissue. And you see that cornea is bit clearer than before. And you can see the PI and the pupil very nicely. So I will just remove the air. And you can see that DM, that edge is also, so it is perfectly within this.
So we have Dr. Rajesh Sinha also who's joined us now. Thank you, Rajesh, for joining in. You came at the right moment when Sir is just about to.
Okay, thank you. Thank you. Actually, I'm sorry.
So now we are in the position like to put the graft. देखे ना centration देखे नहीं.
Okay, so you have already prepared the DMEK roll, sir?
Just I have finished the preparation. I always prepare just before putting it because that air I actually use that time because the time is very important. The time of air tamponade is 3 to 5 minutes. So bleeding time of the patient. So I will come back to the tissue again. And it is so, if you have such kind of table, I will send you the design by me.
Yes, sir. Yes,
It is
sir.
by
Please
some
send that.
Ahmedabad company. It is very nice. So you can easily, so no need of every time you shift the microscope and you shift the table and sometimes your table moves. So you use 2 sponges so that it should not drag to one side.
So this is nostalgic. We are remembering the way you came to RP Center and you taught us this technique. And every single step is a,
So you see that I am trying to see how the things behave. It is not a very tight skull, as I said that the age is around 70. So I just shipped it in a petri dish. So you see that area first I tore during first, that sometimes happen with aged, but this is almost flat kind of scroll. There is no scroll, so this sometimes gives you trouble. If it is, so it is just like you see. I try to see the S mark in this position. It is here I can see. So I will put the injector inside and try to do it in that manner. Let's see. But 60% cases it is easier to go with it.
So your
Center
injector is
data.
IOL injector?
The same injector, I have never changed it because it gives me very good and I found it is more quicker. So the trick for me is that the quicker surgery there will be less endothelial cell loss. That is also true for phaco also. If you spend less time inside the anterior chamber, there will be less tissue damage. So you see that you see that this is the thing I have learned over a period of 3-4 years. It gives 2 purposes. One is to leave the speculum. Second one is if anything comes out, the tissue will not go to the drainage system. And you see that you check the pressure, little bit shallower. I make it little shallower, and then I hold the lateral edge of the leaf. I go like that. I know it is on the left side, so I go like this. So when I go like this, I have to think what is the direction, and I try to move the thing. Like this is the other end. I am using a like iris repository in other hand, so I could actually keep the fluid. The problem of flat scroll is always there. You are not sure that which side is which side. That is the problem. But normally people used to give suture at this thing, but I normally do not give. Let's see. I think I am in a right direction. I could see that A stamp. I'll show you. So I am in the center, so I'll just put
Very
little
nicely unscrolled, sir.
Yeah.
Very
Very
nicely
nicely,
unscrolled.
yes, sir. Beautifully
Very
done.
nicely unscrolled, sir. Beautifully
no,
unscrolled.
this is the jalda. So basically this,
You can see
you
the
have
hair
to be very
follicle.
careful. Little bit of space should be there before sometimes there will be iris trauma and there will be bleeding. It happened in RP center.
Yes.
So I always remember that. So you just put little layer, check your S. S is there. Can you see it?
Yes, sir. Correct.
No.
Correct position. Yes, sir.
Can you see it? I'll show you again.
Yes,
sir,
yes, it is visible, sir.
It is visible, sir.
Clearly visible.
So-
We can see that.
I'll show you again 2 cc. First 1 cc, then 2 cc. 2 cc in the fast go you should not, because you do not have much control on air. But 2 cc, you when you complete it, you just give 2 cc. So you see that this is my tamponade. So there is a rim of fluid here. So I like this rim. There should not be any. This is like 25 to 30. The pressure is between 25 to 30. So people can see how the S look like.
Yeah, now the S is very well seen, sir. Magnified S.
You can see.
Yes.
So दे दो जल दो. So so my surgery is over. Basically I put a cautery here and I'll see this patient after say 1 hour under slit lamp.
And
So I'll see the fluid level.
so
Thank you, Namrata, for giving me opportunity for this Surginar platform and show you. I think it is perfectly for me and the day is good for me. So
Looking
you see
absolutely
that,
perfect, sir.
It was long due and it only happened now. We had wanted to.
this is the graft is perfectly centered and that the patient will be doing very good, I think.
Excellent.
So from after 3 days he will able to see very nicely.
thank you, sir.
Any question?
Great job.
Beautiful, sir. Wonderful. Again, I've learned 2-3 things new from you today.
Just one question, sir.
Yes.
Yeah. What was the size of the main incision, sir?
3 millimeters.
Men 3 millimeter.
3 millimeters.
Okay. And you don't put any suture in this?
No.
No, normally no. 97% no.
Okay.
And many
And
times
do you-
I use main port to give air injection. It depends on AC dynamics also. So if I feel that I have easy access from the main port, I give air from them, at least little bit of air, so that graft, should remain in the center. That is a very difficult part. So there is a saying that you should not be try to 100% perfect in centering in case of DMEK, because you may lose time and at the same time you will lose more endothelial cells. So when you are right that you are 8.5, your graft is accommodating within 8.5, it is perfectly fine.
Yesterday, when we were planning this Surginar, so I said, Basak, you're going to do a DMEK. He said, okay, 17 minutes is my time.
No, so how much time I took?
You hardly took
20
17 to 19 years.
You hardly.
I
took
said
any-
maximum normal time is 17, 18 minutes, but here I will take 20, 25 minutes. I do not know.
No, you took
It
hardly
was-
any time.
We had an excellent time with the participants, which of course are not available for questions. But thank you for the participants. Thank you, AIOS,
Thank
for
you,
this
sir.
honor. We are so honored, like surgeons like Dr. Mrinal Das, Dr. Sanjeev Banerjee, they are
খুলে দে না, এটা খুলে দে না, মাস্কটা খুলে দে না।
consider themselves in a big podium.
এটা মুখটা দেখায়।
It's a very big platform for them, and that they could operate. And we are also humbled by this gesture. Thank you, Professor Namrata Sharma. Thank you, Professor Rajesh. Thank you very much.
I'm really sorry to have joined late, sir, because I'm really sorry to have joined late because I was in a flight. So just now.
But this is
landed, so-
wonderful, that 1.5 hours and we have done 5 cases.
Yeah,
Perfect.
yeah.
5 cases, 1.5 hour, including one DMEK and one SICS.
Yes. So
This is outside your regular course, I mean.
everything was perfect, sir. The way you showed your OT, all the surgeries. We never had a demonstration of SICS and phaco and DMEK all in one go, and all types of cataracts. We had plaques, we had SICS, we had the state-of-the-art intraocular lenses, the machines. I think that that video that you showed, sir, Dr. Debashi, sir, that is for the keeps. I mean, it was just too good. Entire OT, how autoclaving is done,
We
and
follow a system, so we wanted to share
yeah.
with all who are on live and who will see it offline later. Yeah.
And so best part is that all the people have watched it from their own laptops and desktops or mobiles in the comfort zone of their houses or their residences or their offices and their hospitals. And we have watched you, and thanks a lot for allowing us to peep into your operation theater. You have operated from the comfort zone of your center, but I'm sure it's a great teamwork and great organization. This kind of a thing
Zero করোনি?
requires huge amount of organization. It is not easy to bring so many patients, so many surgeons, so many types of surgery. Your entire OT team, we are grateful to, especially your nursing staff, your technicians, and thank you so much, sir, for doing this. Really, thank you. This is
Thank
for
you,
the
so
app, guys.
thank you, Professor Namrata. Thank you, Professor Rajesh. Thank you.
Thank
Thank
you,
you, Rajesh and Namrata.
Thank you,
Thank you.
sir.
Bye bye.
Thank you,
Bye,
sir.
bye, bye,
Bye,
bye.
sir.
Bye bye bye.
Thank you,
Bye.